Okay, Phil, sorry, we're not going there. We're going over to the Institute. Phil? Okay, Phil. Sorry. Phil? We need to get over to the Institute. Okay, that must be Dr. Pena out there. Oh, here we go.
Barry, I know you do that intentionally.
We have... No, I was expecting you to throw snowballs at us.
Okay, good morning, Barry. I think we finally arrived here in Miami in Lab 2. Thank you. Good morning to the panel. Good morning to Link and the distinguished panel in Germany as well. To my right, my good friend and colleague, Jim Benenati, will be working with me today on the case, as well as Juan Gomez, one of our excellent fellows. Juan is going to give our introductory vignette, so please, Juan, take us through it.
Thank you, Alex. Good morning. We bring you all a case of a 64-year-old male with bilateral popliteal aneurysms. Next slide, please. These are our disclosures. Next slide. This is a 64-year-old male with a history of a AAA status post-EVAR. 1 month post-procedurally, the patient developed acute right lower extremity pain with distal emboli to the tibioperoneal vessels and related to a known 4-centimeter popliteal aneurysm. Patient had successful thrombolysis and reconstruction of the artery with overlapping stent grafts, and the patient now returns for a repair of a left-sided popliteal aneurysm. Next slide. Other than aneurysms, past medical history is significant for hypertension and coronary artery disease. The patient does have a strong history of smoking of 20 packs per year. Next slide. Physical exam was positive for a palpable left popliteal fossil mass, otherwise negative. Next slide, please. And even though we're going to be focusing on the left side today, we wanted to briefly show what we did for the right aneurysm. This was the presentation non-invasive examination, which demonstrated markedly decreased amplitude at the level of the right ankle with flattening of the metatarsal waveforms. Next slide. Ultrasound demonstrated a complex aneurysm with extensive mural thrombus with post-obstructive waveforms distally. Next slide. Next slide, please. The CTA demonstrated a single vessel run-up via the posterior tibial to the level of the ankle. Next slide. Angiographically, you can see a broad cutoff at the level of the mid-calf of the anterior tibial and peroneal arteries with a distal emboli of the medial and lateral plantar branches of the posterior tibial artery. Next slide. Thrombolysis was performed for overnight. Next slide. Post-thrombolysis, there was a recanalization of this lateral and medial branches of the posterior tibial artery and some recanalization of the anterior tibial to the level of the ankle. We performed overlapping viahban stents with excellent angiographic results, reconstructing the popliteal artery. Next slide. This is the pre and post non-invasive studies demonstrating waveforms pretty much back to baseline on the right. Next slide. Now back to the left popliteal aneurysm that we are going to be planning on treating today. CTA from March demonstrating again a 15 millimeter aneurysm. Ultrasound from same year demonstrated a slight increase in size measuring 2.1 centimeters. Next slide. Today's plan is to perform the vascular repair with a stent graft of this left-sided 2.1 centimeter aneurysm.
Thank you, Juan. And I neglected to introduce everyone in Leipzig to Dr. Alex Powell, who's leading the discussion from the Institute along with Dr. Benenati. Alex?
Okay, thank you very much, Barry. And thank you, Juan. This is a very interesting case, at least in our minds. It shows, of course, the natural history of what can happen to these popliteal artery aneurysms. And while the left side aneurysm is not particularly large, it has grown a little bit to about 2 centimeters. I think on the previous history, it's pretty clearly indicated that this is a person who has embolized previously and this warrants treatment. And maybe we can get some panel discussion at that point. On that point, I wanted to take you through what we've done prior to going live. Again, this is a patient who's undergone previous endograft placement in the aorta, so it'd be very difficult to go up and over. We're fortunate that he's not particularly big, and we achieved antegrade access into the left leg. And I just want to take you through a small common femoral artery aneurysm. I'm going to take you through the mid-SFA. I'll subtract the image so we can see it a little bit better. And again, you can see in that distal SFA a small aneurysm there and an area of some calcification, which we'll talk about in a little bit. And of course, here's the most important aspect, which is the popliteal artery aneurysm itself, the distal landing zone, 3-vessel runoff, which I want to show you. You see that we have a marking catheter in place, which of course is one of the critical components of this, is putting the right size pieces in. I just want to show you real quickly that there is, in fact, at this point, preserved runoff with no evidence for distal embolization at this point. I mentioned earlier that measurement is the key to this case. It's putting the pieces together. We don't want to have too big a piece because of the potential for infolding. Obviously, too small won't give us a seal. We also wanted to further evaluate that more distal SFA and what could be a potential landing zone. Again, there's that small aneurysm there, and so we performed an IVUS. And I want Jim Beninati to go through that IVUS finding with you here.
Okay, so what we decided to do, and we do on a lot of these cases, is use IVUS to help us gauge where we are. And we have a pullback here that we can show you. If you want to go ahead and show the pullback. And as you see, as we're coming through here, you'll see we come into the aneurysm, and then as we come out of the aneurysm, you'll see that there's some areas here with some minor plaque, and then we'll come back into this aneurysm that you just saw. And as we go through that aneurysm, just on the proximal side of that aneurysm, there's a kind of a focal stenosis that's heavily calcified. And that, I think, is going to impact what we do, because we certainly don't want to leave that stenosis above our graft. So it's going to that actually helps us determine how high up we're going to go with the graft and whether or not we should, even though that other aneurysm was very small compared to the aneurysm at the knee joint, we're a little bit concerned about the plaque, the calcium, and leaving that behind if we just stent below this segment.
So you're trying to identify, just for the audience that may not see this type of disease or use this device, frequently healthy to healthy landing zones. Is that right, Alex?
That's exactly right. And so if we could go back to our reference monitor, and we'll again reorient you as to what the exact area on IVUS that we're talking about. So I'm going to take all the contrast off, and there's a small area of calcium that we're just coming to there with the contrast column. And again, this is our debate. While we have a very high patency with our viahban endografts, it's not perfect, and we're always looking to say, how can we improve this patency? And we do think that, as Jim pointed out expertly on that IVUS, there's a small area of stenosis, relative stenosis at 5 millimeters, an area of calcium. And it may seem a bit excessive, but we really think that we need to take this graft up to kind of the mid-SFA that you're seeing here. And of course, we would welcome any opinions from the panel as to where they would land this graft. An alternative argument could be made that it could be below all that area of disease, a few centimeters above the patella, and ignore all of it. But you've heard our arguments why we're planning on extending it higher here.
So Barry, maybe you could ask people what to do, but we could do this possibly with one piece if we ignored that distally. When we did our measurements with IVUS, they correlated fairly well with the angiographic measurements, but in fact were slightly smaller. And we know that no matter what, we're going to have at least a millimeter taper from distal to the aneurysm to proximal. So we're looking at like a 5.8, 5.9, 6.1, 6.2 measurements below the knee joint, going up to 6.7 above the aneurysm, and then up to 7 and a little over 7 above the area of calcification.
Okay, yeah, I'd be inclined. I think, these aneurysms, while we look at them as focal, really very frequently involve much of the superficial femoral artery. We see ectasia that precedes the development of the aneurysm lower, and I think covering proximally makes a lot of sense. Does anybody on the panel feel otherwise? Tony?
Could I just ask a very good discussion, guys. If you were just to treat the distal lesion, could you keep the endograft below the flexion point, and therefore understanding that if this gentleman lives long enough, and he probably will, that area eventually will need to be treated, but could you get a better primary patency rate just by doing it segmental and following him over time?
Tony, it's a very interesting point. I think the answer is probably not that we would be covering the flexion point. Anyway, can we go on Smart Master?
Okay, well, Tony or Barry, the other issue is, I think, to point out, and I know Tony knows this, but unlike a AAA where size matters, even if we follow them over time, if it doesn't grow, we're worried about thrombus in that, and so it's more of an embolization issue. But Alex was very careful to point out before we came live that distally, we definitely want to leave some space if this goes down and he needed a fem pop or there's something. So we have plenty of distal room that we can work with. So we definitely don't want to go all the way down to the trifurcation or the bifurcation.
And we're just bringing our first, in the interest of time, we want to work and talk. And here's our first viahban that we're introducing here. This is a 7 millimeter diameter by 15 centimeter long. Again, as Jim was pointing out, we've got a nice long landing zone. We want to be cognizant of the fact that if this fails, we want to leave an area for a potential fem-pop bypass.
Okay, I might, Alex, just go to Dirk and ask if there might be any questions from Leipzig about this case at this point. Dirk?
Yeah, I think we are very attentively following your discussion here, and I think it's a great case you picked, very interesting. Well, we have opinion here from our surgeons on the panel, Dr. Godby. He does a lot of endovascular and open repairs, so...
It is definitely a very interesting case. In my experience, after about 100 cases of endovascular treatment of popliteal arteries, if we have troubles with these cases in the follow-up time, that arise from the first popliteal segment. In the first years, we try to get the reconstruction very limited to the aneurysms. But the degeneration of the popliteal artery in the first segment of popliteal is really significant after 3 to 4 years. We have enlargement in these parts, and so we shifted to another strategy that we cover the first segment of the popliteal artery regardless their stenosis and their diameter with the viahbans, and the results are now definitely better.
So that's actually very much in line with the strategy they are applying now in Miami in that case, right? Okay.
Ready to go?
Yes, thank you.
Okay. We appreciate that point very much. We're going to go ahead and deploy this first segment, and I'm glad to hear transatlantic consensus on what we're doing here.
Ready?
Yeah.
Here we go.
And here we go. So pleased to see an accurate graft deployment. We're going to go ahead and balloon that just a little bit.
Perhaps you could do a quick single spot for us.
Let me do it to show you where that went. Sorry, it didn't transmit as well as I thought. I hope you can see that, Barry. If not, we'll cone in just a little bit.
I think if you bring the lateral collimators might help. Yeah, that's better. Much better. There we go.
All right, let me give you a single spot again then.
Thank you.
Okay?
Yeah.
Hey, Alex, as you're doing that, can you discuss your surveillance program and what your your experience is about restenosis, or not restenosis, but stenosis development at the edges? What kind of incidents you see?
I think that's Garry Ansel talking, am I correct?
Yes.
And Garry, hello, how are you? You bring up an excellent point, right? This is not something that we forget about. We do routine surveillance. There is a slight disagreement within the group, but at 1 month, but certainly 3, 6, and 12-month surveillance regardless of symptoms, and then really treating this as if it's a surgical bypass graft. In other words, that if focal stenoses develop, we're going to be proactive. We're going to go in and treat these because any stenosis that we've left behind or that develops, in our earlier experience, we kind of left some of those behind, and these people can unfortunately present with an occluded graft.
Hey, Gary, can I just add a comment? Alex and I are on the same wavelength there, but here in Florida, and very different maybe than in Europe, but our local Medicare carrier came out this past year and said that you cannot follow up treatment of any PAD patient who's undergone surgery or an endovascular intervention unless there's a clinical indication. So just routine surveillance now will no longer be reimbursed, at least in the state of Florida, by our local Medicare carrier, unless there's a symptom or a clear-cut indication to do that.
Just don't let them come on vacation in Ohio. We still get one that they get paid for. So we actually don't do the 3 months.
A little distal.
We do the 6 to 9 months evaluation. And my own personal experience is the development of edge stenosis is much less common in these because we tend to be using big stent grafts, which even in the SFA trials for atherosclerotic disease have a much lower incidence of that.
Alex, can you just tell us briefly about anticoagulation?
So this patient is fully anticoagulated for this procedure. We checked an ACT before going live. I know we've done a number of cases with bivalirudin earlier in the week. Let's just do that. Okay, that's good. But we're using standard heparin in this case, and the ACT before going live was 250. In terms of post-procedure, patient will be on an antiplatelet agent, but will not be on Coumadin or anything like that. No one, I don't think anybody would put on Coumadin.
I think we can go to a 10 here, not a 15.
Bob, did you want to make a comment?
Measurement here.
Dr. Smouse has a comment from the panel here in Miami. Bob?
Yeah, Alex, in a follow-up question to the follow-up question, we've had several patients now develop expanding type 2 endoleaks. And, we're treating these things for embolization and not necessarily rupture. So a little discussion, or if you could tell me how you handle those. And we've also had a couple, too, that have had severe, I don't know if it's severe, but moderate to severe long-term irritation or pain after treatment of these aneurysms with ambulation without any discernible cause, no elevated white count, etc. And I wonder if you've had that experience at all.
Addressing those issues, Barry and I, of course, welcome your vast experience within the group as well. We have not had a type 2 endoleak that's led to expansion that I can recall, Bob, although I'm very interested in that history. We've seen some actually, interestingly, post-surgical bypass.
15 or 10.
I think probably a 15.
Yeah, we have, while you're getting sorted out, we have seen some type 2 endoleaks following surgical bypass, but we recently reported, in our own experience, we've not actually seen type 2 endoleaks from this. Regarding pain, I think we've not seen it just from the endograft. When patients have very large aneurysms and can get compression and compression symptoms, I think it's a somewhat different situation.
Yeah. Bob, I'm very interested to listen to your question. We've also identified a small group of stent patients and with SFA stents. I think everybody has maybe seen that as well with some pain, but I can't say that I've seen it in greater proportion with the stent graft patients here. But it's interesting, and maybe if we talk to them more afterwards.
We have had one patient that we put viahbans in, a young patient that had aneurysms, very atypical, not the geriatric patient, who developed an inflammatory response ultimately as a result, probably had an arteritis in the first place, and we needed to actually explant the devices. And we've seen that on rare occasions with bare metal stents who develop pain and inflammatory change, and it's been presumed to be nitinol allergy in the bare metal stent.
No, that's a good point, and that was offered to the one patient who had the persistent pain that we could do a surgical explant, and he actually declined, but it was an interesting finding.
Here we go. Here goes the second device. I don't know, Bob. We don't see that. Maybe we should review your techniques.
I don't think that's necessary.
Okay.
Yeah.
Okay. We're going to, again, keep deploying and talking as we go. I know we have about 5 minutes to go. And what our plan now is to angioplasty, or
Jim, we just
at least use a balloon,
Miami.
So looking at the proximal end of that stent, Alex, maybe you could, that viahban, you can see that it doesn't look as if it's reached nominal diameter.
No.
Is there a plan to extend proximally or leave it there? I'm not sure exactly where it wound up. But
Well, you know what? I'm going to show you an interim angiogram here.
Hold on. Barry, if you look at this one single shot here, you can actually see there's some infolding in that graft. And go ahead now.
You know, we're going to do an angiogram. Not that this is a completion angiogram by any means, but I did want to show you that area. And again, a balloon for ironing out is coming.
Yes.
And
So